Good evening. It's a pleasure to be here with you all tonight and would like to thank you for the privilege of addressing you. We'll be talking this evening about the COVID experience in Houston, where we've been and where we think we're headed. So I want to go back a little bit, talk about what happened in Houston. This has been a long, strange journey for most of us with a disease we didn't know existed a year ago. And if you talk back to when disaster planning really started in Houston, it was in late February and early March when the health center we convened our first sort of meeting about what we should be looking at this as we saw our friends in the Seattle region starting to struggle and early signs that there were cases, a few cases in New York, but importantly watching our colleagues in other parts of the world struggle to manage this wave of a new infectious disease. Really jumped into things in Houston in March. March 13th was the day that everything really started to collide for us. We had closed the rodeo early. We were now doing daily calls within our health systems, and a Texas Medical Center collaborative formed with the executives from all of the anchoring Texas Medical Center institutions getting on a conference call, initially once a day, then twice a day, with CEOs and then the chief operating officers in the afternoon, talking about what was happening locally and planning as we saw our colleagues, particularly now in Seattle and increasingly in New York, struggle with how to manage this disease. During that period, we went through all of our disaster planning, and Houston is, we're used to disaster planning in the health system. We get hurricanes not infrequently. We've been through all those, but this we knew was going to be very different because of the sustained duration we were likely to need. And with our previous disasters, never had to manage and think about how we would manage for extended periods of time, especially with personal protective equipment needs going up dramatically in our health systems, figuring out how we were going to keep our employees, our physicians, our nurses, all of our staff safe as we were managing these patients. The graph that you're looking at here shows that what happened with our daily positivity rate all through the months, these last several months. And I want to draw your attention to the left-hand part of the slide, and that's really represents the month of April, moving into May, and see how few patients we were finding during that period. Now, that's a little bit artificially low because, as you know, during those first couple months, we struggled significantly with adequate testing. We had extremely limited testing at our hospitals, none initially, all of the labs having to be sent out of state to be run, or a partnership that we collaborated with the University of Texas Medical Branch in Galveston for their in-house labs. Methodist had spun up their own labs, but this took a long time for us even to know how many patients we actually had. But as you can see, moving through May, as we move into June, still the overall numbers are relatively low. It wasn't until we got into July that things really exploded, and we'll talk a little bit more about that. Dr. Patel, during her session, will talk more about how our medical care has evolved and how the way we treat these patients has changed dramatically over time. We'll talk a little bit about the community response, and one of the things that we've really seen now as things have continued to improve is Houstonians doing a better job of taking care of Houstonians. The significant increase in mask wearing, the social distancing, the efforts from the governor, from the mayor, from the county judge, all have helped make this a safer city to be in for us right now and have helped us get control of the numbers that you can see have steadily declined through the months of August and into September. When this really first started, there was a lot of fear with healthcare employees around physicians and nurses worried about themselves getting sick and what would happen with their family. I'm happy to be able to report that we have done a really remarkable job in getting the adequate PPE and being able to take care of our healthcare workers. Very few frontline healthcare workers getting sick on the job. I think that many of them who ended up contracting COVID actually got it out of the hospital, where perhaps they let their guard down in some ways. Not perfect, but have done I think, a really remarkable job at keeping people safe. And I should mention, Dr. Patel, if you want to weigh in on anything, you're of course welcome to jump in and tell me when I've got it wrong. So testing is one part that I mentioned earlier. The testing has really changed dramatically. Right now we have, without question, capacity to test anybody at any time at any of our healthcare institutions where we feel we need. There are still challenges with reagent supply that we're constantly monitoring, but testing has really no longer become a barrier in any of our acute care hospitals. In the command center that we stood up, I want to just touch base briefly on. This is a multidisciplinary group of people who meet are working all day during this and at times all night, where we're putting out and collating and assembling best practices, distributing those out to all of our hospitals so that we're all doing things the same way. You heard a lot during the months of July and August, particularly in July, about hospital capacity. And there was a lot of confusion in early July around how much capacity hospitals really have. And part of that seems strange to folks who don't live and breathe in hospitals, but what we really did during this period is we made capacity. We took units that had been mothballed or old post-operative recovery areas in hospitals that were used when patients come out of surgery, converted those to acute medical surgical beds. We made new ICUs in areas that hadn't been ICUs before. We made capacity and significantly expanded it throughout our healthcare system. And when we talk about even the burden of these patients in the hospital, we still had a hospital full of other patients. We had heart attacks didn't stop or go away, cancer didn't stop and go away, appendicitis didn't stop and go away. So we still had to manage all of that on top of the COVID volume. So to talk about overall hospital capacity really doesn't make a lot of sense with the kind of COVID waves we were seeing, and would only be true for full capacity if you talked about shutting down the hospital completely, kicking everybody out, and all we're going to take care of is COVID. Fortunately, we never got that bad. During the early parts of July, you can see when the hospitalization numbers were so high, things were pretty stressed. We had patients all over the hospital in multiple different units. We had to recruit physicians and nurses who don't typically take care of these types of patients and make them assistants and aides for our critical care physicians and for our critical care nurses to really expand their ability to manage increasing numbers of patients. We had to institute a no visitor policy, and that's been incredibly stressful on friends and family and patients. We've fortunately been able to relax that over the last couple weeks, but we know that was very stressful. I'll tell you the one area it's certainly stressful on the patients, but the added stress that puts on our nursing staff, where they become the sole point of contact for our patients who are uncomfortable, who are ill, trying to get contact, puts a significant pressure on everybody. So we're fortunate that we've been able to relax that. But it was really done for safety, for both visitor safety and staff safety. With just many more people moving in and out, the ability to control infection is just harder to do. We did suspend elective surgeries during this period, and that was during the peak volumes, and that was to preserve capacity. I want to just touch base though on elective surgeries, because elective and surgery, for what we talk about, there's a bit of a disconnect with, I think, the general public at large, where they think nose jobs and tummy tucks when we talk about elective surgery. But for us, elective surgery is anything that we can schedule. So if you are in chronic pain from a degenerative hip and need a hip replacement, we consider that elective surgery. If your cardiologist has told you that you need to be scheduled for a bypass surgery because of your heart disease has gotten bad enough, but it's not an emergency, it's not being done immediately right then, we consider that elective surgery. So we pushed all of those off. Cancer surgery, if it could be delayed a little bit because the fear of metastasis wasn't that large or not feared, those were all pushed off as we tried to manage this volume of COVID. So many patients had their healthcare suspended during this period or paused, and we were greatly relieved to be able to bring back elective surgeries as we got handle on the wave of patients that were coming in. Emergency volumes are interesting. So one of the things that we definitely have seen during this is emergency department volumes dropped significantly. They've dropped during the peak of the pandemic for us, which was in middle of June, but they've stayed depressed, with volumes now still being 15 to 20% lower than we would expect them to be compared to last year. Some of it, we think, are patients who've learned to get healthcare other ways through the digital space, through virtual health visits and telehealth, which we think is a great way for them to access their care. But we're also concerned that people are still withholding from care, afraid to come in, afraid about what will happen. And we have certainly seen a decreased number of heart attacks and strokes during this period. The concern for that is that we're sure people are ignoring small heart attacks and strokes. There's nothing about COVID that is protective from you not getting a heart attack. It is people thinking they can wait out this chest pain because they're afraid of the hospitals. So we've done significant efforts to try to demonstrate that you can safely come to our healthcare facilities and get care. One of the other interesting areas is trauma. So all of you have seen the roads that have had far fewer cars, and as a result, you would think, well, there are going to be fewer accidents, and that's kind of true. There certainly are fewer accidents, but there are more bad ones. With the lower number of people out driving, we saw higher rates of driving speed and more severe accidents. So our severe trauma patient population actually has been very stable during this whole time. And one of the unfortunate things of the social pressure in an event like this, we've seen an increase in interpersonal violence and domestic violence, and we've seen an increase in shotgun and not shotguns, but gunshot shootings, and as well as stabbings during this period as tempers flare in this stressful period that we've all been in. This is an example of material that when you see this during the presentation tonight will be a week late and dated. But this is the way we watch and monitor at the hospital system and the health system to see what's happening in our community. We review this data every day and use it to help guide what we're going to be doing for patient care, but also the guidance we'll give the community. So we look at the effective reproduction rate, and this is the rate of which the virus is spreading. So less than 1 means that if someone has COVID, they're not likely to give it necessarily to another person. It would be the percentage of that drops. If the reproductive rate goes to 2, that means for every person who gets COVID, they're going to infect 2 people. So to know that you're controlling the infection, we want it less than 1, and that means it's starting to dissipate as it is. We also look at how many new cases we get every day, and we want to see that steadily falling. And hospitalization is particularly important, especially in the hospital business. We want to know how many patients are being admitted to the hospital and what that capacity constraints means for us. For those of you who haven't seen the TMC dashboard, this is that same material presented graphically, and this is updated every day, and you can really follow how the community's done. I think this is a really nice demonstration showing where we are and where we were a week ago or 14 days ago, and then shows the goal where we want to get. We want to get into the green on all of these. That is a reproductive rate of less than 0.7. We would like to get less than 200 new cases a day, and a less than 5% positivity, which we are all doing right now locally with the exception of the new cases per day. This is another dashboard that we've put together internally to monitor the Memorial Hermann specifically volumes. I won't go through all of it, just to say that these are the kinds of materials that help us be able to manage. The picture in the center I want to draw your attention to, and I'll come to that, blow that up a little bit more. We tracked by zip code where patients were coming from so that we could help identify hotspots for community outreach. There's one hotspot here which is around our Memorial Hermann Southwest campus. Definitely saw a significant spike from patients in those areas, especially amongst our Hispanic community. And by doing that, we could do targeted education to that community in community centers, using local groups as well as leveraging our relationship with our Hispanic TV and radio so that we could get the message out on how to stay safe, social distancing, hand washing, all the things that we know that are really important. We also put this up to look at the healthcare disparities. You all have heard that there were certainly lots of people, there was a lot of press about this in the month of July and August about the Hispanic population. We certainly saw surges in that population. Overall, our balance was pretty even between Hispanic, Caucasian, and African American. By percentages, we know the African American community was hit disproportionately hard in this because they represented a similar percentage of overall patients when the overall population is lower. But watching this allowed us to track both age, demographics, where people came from, socioeconomic impact, so we could better move proactively to work with those communities. I'm now going to turn it over to Dr. Patel, who's going to talk a little bit about the TMC campus specifically and some more details in the responses.
Good afternoon. I'm going to really talk about our experience and how we had to prepare the Texas Medical Center Memorial Hermann campus to prepare for COVID-19. So when we started hearing reports from China, we were worried because we've looked at SARS and MERS and other types of viral pandemics that were started and luckily had been halted. When we started hearing about cases increasing in China, we started brushing off what we already knew, our pandemic response. Our pandemic response plan was really created 10 years ago in preparation for this. And as every virus in the in the world has risen and fallen, we've kind of brushed up on those learnings to make sure that we're incorporating everything we could into our future planning. And that's what we started to do in January. We also started to talk to the international community. We started to talk to China and Italy and Spain as they started getting rising volumes, as well as New York and Seattle. And the reason for doing this is a brand new disease. We had to learn on the fly. We couldn't wait for randomized controlled trials to be published. We wanted to know what the front line was feeling, what they were experiencing, what adjustments they were making, and how they practiced medicine, how they isolated, and so forth. So we started having those conversations almost every night at 2 in the morning, for adjusting for time, but it really was something that we were aggressively learning very quickly as the world was learning. We started our executive briefings in February. We put up our command center on March 2nd, and on March 4th, we had our first COVID-19 patient in Houston. So we started evolving our campus. We started designing dedicated units. We started training our staff. We started redesigning how we take care of ER patients and ICU patients. And then we had to be creative in how we manage masks when mask supplies were low. We had to be creative on how we get convalescent plasma. And every turn, this has been something that we've been creating as we are learning, and every week was different as we learned and we grew. When it comes to the medical response teams, clearly the nurses were well prepared in that they were redeployed to designated units. When it came to critical care physicians, we had to redesign where they currently practiced and created new units that were dedicated to COVID ICU care. And the most important part for both nurses, physicians, respiratory therapists, and the entire team was to make sure that they were perfect in their PPE, so they weren't exposing themselves or their families to a new virus that we weren't really sure how contagious it really was and how quickly it would spread. So we also created lots of learning opportunities for emergency medicine physicians to make sure they were trained, because they were the front lines and they were seeing twice as much volume because they were seeing the admitted patients and the discharged patients. And then we took our hospitalists and we redesigned units and redeployed them to make sure that they were able to take care of this very specific population, and that they weren't actually then traveling across the hospital to decrease the risk of other exposures. But then as this population got trickier and trickier to manage, in that they were very critically ill when they got critically ill. They were unstable, moment-to-moment adjustments were needed, and therefore it really preoccupied the critical care teams, so we needed to enlist other sorts of help. We got our anesthesia colleagues to develop a dedicated procedure team, so when somebody needed an airway or to be intubated, they were there and they could be in and out in the shortest time possible. Our surgery colleagues pitched in and they put in lines for us to make sure that we actually had additional help to take care of the other parts of patient care. And then we also send our critical care physicians to the community, because we had some depth and the community practice physicians did not. And if one of them got ill, then they really were handicapped. So we made sure that we were spreading our ability to take care of the most critically ill patients. We also developed a dedicated ECMO unit. ECMO is essentially a lung bypass machine. And to put it in perspective, when we had H1N1 and we were really concerned about our ECMO capacity about a decade ago, we only had a maximum of 6 patients requiring ECMO for severe lung disease. In this disease, we actually had a high need for ECMO. We had as high as 16 patients on at any single time. And therefore, not only did we have to create a dedicated unit, but we had to dedicate really specialized teams to take care of this really critically ill population. The pediatrics team, not only did they take care of pediatric patients that we were seeing at our children's hospital with COVID-19, some who were critically ill, some who just happened to be positive for other diseases like appendicitis. But with the pediatric teams also took care of slightly older populations. They went to 18 and 21 just to help out the adult side to increase capacity, like Dr. McCarthy was mentioning. Our OB team also redesigned their whole services, because we did see a significant population of pregnant women who actually were contracted COVID-19, some who developed the disease and some who were just positive, but we had to redesign our processes to make sure that we actually had the capacity for them. Our infectious disease physicians obviously were available for consultative services 24/7. And we developed these teams as patients were more and more complex and our volumes got higher and higher. We became very sophisticated at how to redesign teams to make the maximum use of all of our subspecialties, but also make sure that we're not burning out the teams by making them work 30 days in a row, for example. The other thing we did was we really spent a lot of time educating all of us, all of our physicians, all of our large teams with nurses and nurse practitioners and so forth, because the information that we were learning was changing week to week. One week, standard of care would become certainly not the standard of care the next week, like hydroxychloroquine, for example. So as we were learning bits of information that may help us take care of our patients, we were certainly wanting to communicate that to the entire city of Houston. So we developed virtual seminars that often happened once or twice a week. But the most important communication we developed was using WhatsApp. We developed a critical care community where we shared not only the most recent articles that may have been published, recent little bits of data that may help us change management, but the most important thing we did was we made it possible for the bedside physician, as they were managing the patient, to be able to pull up their phone and send a question to the greater community of critical care physicians, including half of them being academic physicians who may have more access to growing research. To be able to answer that moment-to-moment question. How do I manage this patient? Should I use this drug? Should I use anticoagulation? And I think that really helped the community move very rapidly forward, accumulating all the new information in managing these patients that were very complex. And then we needed to continue to change our environment. We created new pathways. We protected our staff. We created new ways of managing patients, including putting a lot of our monitoring pumps outside the room. We had to reuse our N95, so we created mechanisms to do that, and we also shared that with our community. We also had to redesign how we take care of patients. For example, we knew that when patients needed the highest level of support, for example, ECMO, we needed to transfer patients to the medical center in general. We knew that the small hospitals could manage a lot of patients, but may not be able to manage the most critically ill patients. So we actually designed a flow through smaller hospitals to larger hospitals to the Texas Medical Center, and more importantly, even flow backwards, in that when we needed patients to recover, we really wanted them to recover closer to home. So those types of processes, we were in constant communication. So as Dr. McCarthy had shown you this graph previously, this is the number of hospitalizations, both ICU and to the regular ward. In the beginning, we had, in April and May, in the light blue zone, we had a really controlled process. We could take care of every patient, put them in exactly the right place, and we felt very comfortable managing. But as you know, after Memorial Day weekend, as the volume started to increase, we had to redesign every week what we did to make sure that we were creating new units, creating new teams to take care of these patients. And at peak, we had a large volume of patients in our hospital. That's when we had the 16 ECMO patients. We had 160 patients in-house at the Texas Medical Center, and we were starting to stretch our resources. And luckily, the city of Houston came through social distancing and mask wearing. We were able to get the volumes down. But we did use the highest number of ventilators we've ever had in the history of the Memorial Hermann TMC campus, the highest ECMOs, the highest number of critically ill ICU patients. So we were stretching all of our resources to near maximum. The other thing we had to redesign, just like the system redesigned data to be available everywhere to understand how to manage patients throughout the city, we also needed to recreate that for our campus. So this is a locally designed dashboard to understand where those patients are. So every time a patient came into the hospital who was tested and tested negative. We knew which patients those were. But as we were testing more and more, we needed to understand where every positive patient was to make sure that not only did they get appropriate therapy, but that they had got appropriate isolation, and we protected the teams, and they were in the right place. And so we created these dashboards to help us manage the day-to-day movement across our campus to make sure that we are able to do that effectively. And as you can see in the bottom right, you can see that as of a couple weeks ago, we actually had about over 1,500 patients that we've seen and managed on the Texas Medical Center campus. And really, as of today, we're close to 1,600 patients. This is on our campus, we actually saw a broad range of patients just like other campuses, but we had something unusual. If you look at the 25 to 30-year-old, we had a large number of patients in that age range who were admitted to our hospital, and that's really because of our OB population. We had, as I mentioned, lots of pregnant women who were transferred in, who were positive with either COVID disease or potentially could have been developing COVID disease and it just turned positive. So that's one of the reasons for the spike in that generation of patients. You also see the 0 to 5, you see a large number, and that's because of our children's hospital and patients being transferred in or coming in through our ER. But the most unusual thing when you look at this, for me as an intensivist, is when you look at viral diseases like the flu, you don't see this distribution. What you generally see is 65, 70, 80-year-old patients who develop severe viral pneumonia or viral organ injury and require hospitalization and critical care. You don't see patients who are 18, 20, 30, 40 being in ICUs, a lot of them who have no underlying medical conditions, being critically ill, requiring ECMO. And I think that has been the hardest part from a clinician standpoint in managing the disease, is seeing young, healthy people in critically care units. The testing options over time, we continue to increase, but I would say that this is the one area that in the beginning was a problem. We could get testing, but as the country and the region started increasing the number of tests they were ordering, there were significant delays from these national companies that couldn't keep up with the volume. And I think that once we started to get our rapid testing, our 15-minute testing, that was our biggest game changer, and it really changed how quickly we were able to manage patients, how quickly we were able to move them across the hospital, how quickly we could get them to the ORs. I think that was the biggest game changer. And in future pandemics, I think that's one of the most important drivers, is how quickly can we get the test. And the faster we can get it, the better we can all manage these patients. So I'm going to take a 5-minute break there, and so we'll see you back then.